is enough. From my journey as a critical care student to now practicing as a super specialist consultant, one constant pillar of strength has been him. His mentorship did not end with our training. If anything, it has become stronger. Even years after passing out as his student, he still continues to guide us with the same dedication and patience. At any hour, we know we can call him, text him, discuss a difficult case or seek clarity. And he's always there, never letting us feel alone in this tough world of critical care medicine. He embodies what a true mentor should be: supportive, available, wise, and endlessly inspiring. His students do not just learn under him, they grow under him. So, ladies and gentlemen, it is my absolute privilege to introduce my teacher, my guide, and my mentor in the truest sense of the word. Please welcome Dr. HARJIT Singh DUMRA, sir. Over to you, sir.
Thank you, Pari. That was one of the best introductions I have. And believe me, I've been to a lot of places in the last 20 years. And thanks a lot. It really brought tears to my eyes. Thank you. You've been a great student, and I hope you have the best of the future. And you're growing at a rapid pace in Surat. And I can vouch that you will really get there very fast. So coming to the topic at hand, and carbapenem-resistant enterobacterialis. This is what we are going to discuss today, and this is a issue which deals with day-to-day problems. This is something which all of you see in your practice every day. And the problem is that although there are guidelines and there are basically review articles sort of being published every year, getting updated every year, but so too we are getting newer antibiotics every year. And hence, that is why we need to get updated with the available armamentarium we have to deal with this growing menace. And I'm privileged to be a part of this discussion because I have an excellent panel here. Dr. Hegde, as Pari mentioned, I am her mentor. Dr. Hegde has been my mentor for all these years, and I could have none better than him in this panel. So this will be a case-based discussion. So I'll start with this case. This is my patient. My slides are not moving. Okay, so this is the patient. This is a 58-year-old man with diabetes. His HbA1c is not controlled. He's undergone an emergency colectomy for a perforated sigmoid diverticulitis. Empirically, the intensivist starts him on piptazo. He has normal renal functions to begin with. The surgeon sends cultures during the surgery which grow a strain of E. coli, which is sensitive to piptazo, and piptazo is continued. This gentleman has a past medical history for hospitalization in the last 90 days with a urinary tract infection requiring IV antibiotics. By day 3, this patient is doing well, and he's shifted from the surgical ICU, and by day 5, his drain is removed. Post-op day 8 is where the story starts, and he develops a fever with abdominal pain. His counts show a steady rise up to 18,000, and he starts developing borderline low blood pressures, and he's shifted back to the ICU, started on a low dose of NORAD. A CT is done on the way, and this shows a new intraperitoneal fluid collection. This gentleman progressively worsens, gets intubated for moderate hypoxemia. The intubation is more for altered sensorium than the hypoxemia, and the chest X-ray shows basal atelectasis. Blood and peritoneal fluid cultures are sent, as you would do, and he's empirically stepped up to meropenem and linezolid. Now, on day 2 of empiric therapy, the patient still is febrile and shows a worsening in his renal functions. By that day evening, this patient becomes grossly hemodynamically unstable, and he started on higher dose of vasopressors and soon graduates to triple vasopressors. A re-exploration is considered, but because of his sad state, it is deferred, and the surgeons put in multiple drains to achieve some kind of source control. The patient eventually grows a positive, beeps positive on the blood culture and shows a positive Klebsiella pneumoniae. And we do an expert carba-R, which all of us tend to do just to sort of ID the bug a little early. And the expert carba-R shows an NDM and an OXA48. Now, just to sort of set the ball rolling and give you some perspective, Most of our bugs in the ICU are gram negatives. We see E. coli, Klebsiellas, Acinetobacters, and Pseudomonas as our most dominant bugs. And most of these bugs have become resistant over a period of time. And you have primarily 4 mechanisms of resistance: the loss of porine challenge, the loss of efflux pumps, sometimes the PBP, the penicillin binding proteins get modified. And last but not the least, you have production of beta-lactamases. And as far as gram-negative resistance go, particularly for Enterobacterialis, your E. coli and Klebsiellas, the beta-lactamases is the commonest mechanism of resistance amongst E. coli and Klebsiella. Now, this is basically the carba-beta-lactamase family, and I'm not going to spend time here. But carbapenemases, as you see at the bottom, we have commonly 5 of them: the KPCs, the OXAs, the NDMs, the VIM, and the IMP. And in India, OXA48 and NDM dominate the beta-lactamase family. Not saying that the ESBLs and MCs are not seen, but our scourge and our menace is the carbapenemases. Now, if you look at some epidemiological data from India itself, and this is the Atlas data, which was sort of elaborated from 2018 to 2022. If you look at the number of Enterobacterialis which showed resistance, almost 41% of these were carbapenem resistant. The Klebsiella is more resistant as compared to the E. coli, and if you see the enzymes, the OXA48s are a little less, and the NDMs are high as far as E. coli go. But in Klebsiella, you have almost equal of OXA and NDMs. KPCs are not commonly seen in our country. And this is the armamentarium you have to tackle these resistant bugs. And previously, we used to resort to polymyxin-based therapies, and then we had the access to ceftazidime avibactam with aztreonam, which have become the workhorse drugs for these bugs. With that brief introduction and just the summary of a case, now I'll go to my panel, and I have some questions for them, and we would like to interact with the audience. So if you have some queries, you can interrupt the discussion and come to a mic and ask us those questions. But I would prefer that if there is a smooth flow, you get us those questions at the end of the discussion. So I'll start with Frenil. Frenil, you run a lab in Surat. So what is the prevalence in the local area, and what is it in Gujarat? Like, just so we can have a ballpoint figure. So what are the CROs you commonly see, and what percentage of that is Enterobacterialis?
We are seeing a lot of them. If we talk about enterobacterials, and mainly from the ICU, all the healthcare associated infections. So I would say my COTs are mostly, I would say more than 90% of COTs are CREs. If you talk about Klebsiella, so I would say 100% so far. Ventilator associated pneumonia, it's a mixed bag because a lot of non-fermenters like Acinetobacter, which is a carbapenem resistant, and Pseudomonas, sometimes pen susceptible or sometimes extensively drug resistant. So I get extremes of them. And if we talk about CLAB, the burden of CLAB is huge, and it is almost, I would say in VAP, it is almost 100%. It's a carbapenem resistant. And if we talk about surgical sites, so yes, post-op, as your case, the CLAB, almost 100%.
So we are reaching that 90 to 100% mark for basically CREs in most of our ICUs. And I think most of my panelists would agree with that. So, sir, I'll come to you. And because you work in a tertiary care center, one of the best ICUs in the country, to this learned gathering, what would you say are your first choices of drugs for CREs?
No, in my hospital, depends, of course, right now we don't have CROs, so we don't have, we don't have Acetobacter, we don't have Pseudomonas, so it's essentially Klebsiella and E. coli. I mean, the carbapenem resistant rates are pretty high, so if I'm suspecting carbapenem resistant organism, I'm suspecting, so it's empiric therapy. It depends when I think if it's a non-urinary focus, which I do, where E. coli is unlikely. A non-urinary isolate, abdomen and urine would be E. coli, but otherwise it would be Klebsiella. There, my empiric choice would be ceftazidime avibactam and aztreonam combination. If I'm suspecting E. coli and the patient desperately ill, then use polymyxin fosfomycin. If the patient is not so ill, even for the E. coli, I'd probably use ceftazidime avibactam and aztreonam pending synergy testing.
So there is a slight difference in your choice whether you are dealing with Klebsiella versus E. coli.
Yes.
And the reason behind that is you're not very confident with ceftazidime avibactam aztreonam.
Basically because of the so-called PBP3 insert in the E. coli, which makes, it destroys aztreonam, it already makes aztreonam ineffective. So therefore, the combination might not work in E. coli if there's a PBP3 insert. So we need to test for the presence or absence of BB3 insert. Only then can you safely use the...
So you'll start definitive therapy once you have
So
some
in a
more
sick patient
data.
where I can't afford to be wrong, I won't take the risk. In a patient who's not so sick, I'd probably continue pending.
And I think that is an important point because when we deal with enterobacterial EC, we usually consider it as a blanket statement that all of them will respond to ceftazidime, avibactam, astronam, but our E. coli is getting further and further resistance and it is becoming more difficult to treat as compared to Klebsiella where the drug is much better. Pratik, you have something else to add?
I would agree with sir that in my ICU we have mainly Kleb for hospital-acquired pneumonia, and most of them showing synergy is sensitive. So KSAV with Astronam would be my choice for only HAP. But when it comes to intra-abdominal infection, UTI, they are mainly E. coli. And as sir said, PBP3 mutation is a big problem in India. So then I would be hesitant to use empirically.
Fine. So the site of infection would also dictate
Decide my choice of antibiotic.
So it is not only the bug, it is also the site which helps us decide which would be the best empirical option. That makes sense. So let's move forward. My slides are not moving. Okay. So this is the Indian Atlas data, and if you look at the sensitivity for MBL positive E. coli and MBL positive Klebsiella, you can see that almost apart from aminoglycoside, astronam, avibactam, tigecycline, and colistin are showing good sensitivity as far as E. coli is concerned, and so is the case with Klebsiella as well. The difference is in the co-production. So in E. coli, you have less of co-production of OXA and NDM. It is predominantly NDM, while in Klebsiella, OXA and NDMs tend to be co-produced in most case scenarios. And the newer BLIs, and we had ceftazidime, avibactam, and now we have astronam, avibactam. The major difference is that MBLs are covered with astronam, avibactam, vis-a-vis ceftazidime, avibactam, where you do not cover MBLs. So how does that happen? Because avibactam takes care of everything else besides NDM, and when you add astronam along with it,
Can we sit, sir?
Thank you.
Sensitivity which came back. So this patient showed resistance to carbapenem. The MICs were very high. The aztreonam was resistant. TG, the MIC was 1. And as polymyxins are usually given only intermediate susceptibility, that was the case. The synergy test was awaited for ceftazidime, avibactam, and aztreonam. Now I come back to my microbiologist Frenel. So a lot of our labs do the synergy test, but a lot of them don't do it. So is there any surrogate way of sort of interpreting this combination besides the synergy? And how reliable is the synergy test in the Indian context?
A synergy test was introduced, I think 2.5 years ago by Balaji sir. They published one paper, and that method was quite crude. And CLSI included from the last year. So it became mandatory to check, because previously we were just relying upon CARBA-R, what you mentioned, some rapid or maybe on the basis of gene expert. So we were targeting only 5. Now there are many which are being produced in the background, which actually we can come to know from synergy. So it is always ideal to send CARBA-R plus synergy together. Okay. About the testing part, the recent method which has been recommended by our guideline, that is Clinical Laboratory Standard Institute, we call it CLSI. The test is good, and it is little cumbersome to process, because we have to deal with broth, so there is a very high chance of contamination. And you can rely we are getting synergy not detected. So that also tells you that there is something which is being produced in the background which is not covered in your CARBA-R.
So just to summarize, the synergy test, if done properly, is completely reliable.
Yes.
Ideally, it should be combined with the CARBA-R to get better interpretation.
Absolutely.
And sometimes the CARBA-R might show an NDM-OXA, which might be sensitive to the synergy on paper, but when you do the susceptibility, it might turn out to be resistant.
Absolutely.
So sir, if you see that kind of a bug, does it make a difference to your antibiotic choice where you have an NDM-OXA on the CARBA-R, but your synergy is negative? Would it make a difference to the choice, or you would still continue to basically go with polymyxin-based combinations?
No, synergy negative meaning they are not synergistic.
No. So you are growing, say, NDM on the CARBA-R, but the synergy is resistant.
So then there's no question, no synergy resistant.
So sometimes the porine channels or the efflux pumps will also contribute besides the carbapenomases.
No, I agree. No, that's what I didn't understand the question. You were talking the second question you were talking about.
Yes. So in that kind of a situation, would you continue a carbapenem?
No, till I get a MICs, no. If there are borderline resistant, sometimes just twice the MIC breakpoint, I might consider using a high dose meropenem as a prolonged infusion. But that's one of those rare situations. But till I get the MICs and all that, I wouldn't.
And in your ICU, what is the cutoff of MICs for meropenem where you would continue to use high dose continuous infusion?
Honestly, at the moment, all the MICs are 80
Sky
or
high.
120, etc. There's no question of having anything.
So are you using any carbapenem infusion with polymyxin?
I've given a talk on that. Meropenem is like a lion becoming domesticated. So meropenem was once a lion, now it has become a pussycat. So
you tend to avoid using it as far as possible.
It's only for community-acquired infections, not for...
Fine. So we have some want of time, so we'll move forward. So based on the AST, the TG cycline was also sensitive in this patient with intra-abdominal sepsis on high-dose vasopressors. So what is the role of TG cycline in the ICU setup in this kind of a patient? Pratik, I'll start with you.
Sir, first we have to see at the MIC of TG cycline, and you mentioned that MIC is 1.
1.
So that is not a good MIC. Less than 0.5 is a good MIC.
Ideal.
0.2 is, sir, TG doesn't achieve good level in the serum. So even recommended dose in sepsis is 200 loading dose followed by 100 BD, but that is as a adjuvant. It should not be given as a monotherapy. So as sir rightly pointed in beginning that TG will be the add-on therapy, but primarily either it will be polymyxin based therapy or newer BLI.
Fine. So very relevant points that even if TG is sensitive and it works with intra-abdominal infections, but when you have a bloodstream with triple vasopressor, TG should not be monotherapy even if you give high dosages. So 200 loading followed by 100 BD should also be started with a polymyxin based combination. I think that's what we agree on. So the synergy test came back as sensitive. Recently, Astronam avibactam has been introduced in the Indian market, and the microbiology laboratory performed an E-test strip assay to determine susceptibility, which revealed that the isolate was sensitive. So the synergy was sensitive, the E-strip was also sensitive. Now, just to show you a little bit of data on the new product, Astronam avibactam, this was the revisit study, around 400 patients, and they compared it against polymyxin carbapenem combination, and out of this, only 4% patients were MBL positive. So all of them were MDRs, but only 4% were metallo-beta-lactamases, and it was a non-inferiority study compared to polybs. But this study did not have a huge chunk of metallo-beta-lactamase producing strain. So they did another study, and this was the assembled study, unfortunately a small number, 15 patients, where they compared Astronam avibactam with the best available therapy, which included polymyxins and phosphomycin, carbapenems, and tigecycline. And here, there was a clear-cut signal that when you are dealing with MBLs, Astronam avibactam scores over the best available therapy, whether it is point of cure or mortality. So, all of us have not been using this new molecule a lot. So what is your initial experience in the lab as far as Astronam avibactam is concerned, Frenel? How is the susceptibility? Like, is it as good as the synergy?
Sir, to be honest, as of now, CLSI and UCAS, these are the two guidelines which we use to interpret the MICs. So they have not come to the consensus for E. coli, enterobacterials. As of now, we have been told that less than or 8 is microgram per ml is considered to be susceptible. So far, we have checked very few with E-test, and they have shown a good susceptibility.
So I was talking to Dr. Hegde early, and can we use the E-strip now as a surrogate for synergy test rather than doing the synergy? Can we do only the E-test for Astronam avibactam and extrapolate it to ceftazidime avibactam Astronam?
I guess yes, you can do that, because actually we were making Astronam avibactam in vivo in the patient.
Because you said synergy test means a lot of good work rightly done to get the right result.
Yes.
And the E-strip might basically suffice with that. So that is one of the new points, that if you have the E-strip, you need not do the synergy, because that will give you equally good data. So moving forward, this patient, based on the AST results, what would you do? Now we have two options here, because it is Klebsiella, and Dr. Hegde mentioned, you have Astronam, ceftazidime avibactam and Astronam as the drug of choice, but now you have this standalone Astronam avibactam. So how do these two products compare against each other? Any thoughts or any experiences in the last 1 month?
I frankly don't have any experience, but in our country it's all about the money. So at the moment, I mean, theoretically, the combination, because, you know, ceftazidime avibactam Astronam is just a jugaad. It's not really been tested in studies. That's theoretical. But all of us, I think, have found that it works reasonably well in the patients who have this combination where synergy is positive. It's worked reasonably well. So, I mean, and Astronam avibactam is an expensive drug, and plus you need to waste the first dose. You know, 1/3 of the vial only has to be, the rest has to be thrown away, which to most Indians seems to be a little, you know. But I have not used it yet, I'm honest. But if I have a really ill patient and somebody who can afford it, then I probably might use Emlavio. Otherwise, I still probably, like you said, I would use the E-test as a surrogate for synergy positivity, but continue to use. But I would
you would have the same thoughts?
But I would use the original molecule.
These are some of the questions which I had. But just to summarize a brief answer as to what is the positioning of Astronam avibactam in the presence of ceftazidime avibactam Astronam in the Indian context?
So, sir, as sir said, it's a jugaad that we are infusing two separate molecule. So the main problem in ICU, we have to train the staff, because there are total 6 infusion is going. So definitely there will be more volume will be going. And if we are using multiple lumens, so there is a risk of CRBSI and all this thing. And when we discharge the patient, like if we want to convert to OPET, then again it is difficult. So definitely Astronam avibactam will be the solution for that. And as studies have also shown that PK/PD target is also better with the Astronam avibactam, but cost will be the limiting factor for Indian people.
So just to summarize, where does the new molecule sort of say is better than the previous combination we have. One, the man hours and the amount of staffing you require to give 6 infusions simultaneously obviously is less with this new combination. So you don't have to combine infusions. The infection rate obviously will go down. The second bit is that the PKPD data for Astronam Avibactam is better than the synergy which we had in the past, and what they call is probability of target attainment for both the drugs is much better. The third thing is that if you are not dealing with Pseudomonas, because ceftazidime primarily is a drug which deals with Pseudomonas, so if you are practicing antibiotic stewardship, then you would say that for Klebsiella, Astronam Avibactam would suffice, but if I was dealing with maybe a Pseudomonas which is susceptible, I might add another ceftazidime, and maybe that is where this new molecule will help. But those were my questions, and I thank the panel and the audience for being here, and we are open to questions, and we have some time, we can take those questions. Thank you. Questions, comments, thoughts? You are an excellent panel there, so exploit their brilliance and academic acumen. Don't direct the questions to me.
So people come up with the Avibactam only.
Can you speak up? I don't think we can hear you.
Yeah. So people now come up with the only, not ceftazidime Avibactam, they come up with the Avibactam only, and then they push for combination with some other third generation cephalosporin. So whether it's useful, and is there any evidence?
So the question is,
Avibactam.
Avibactam isolated is available. So would you combine Avibactam with a broad spectrum cephalosporin and you would get the same results or not? I personally have not used independent Avibactam, so my experience with that is limited.
Even sir, same. I have not used it, the separate Avibactam and combined with the Astronam. So again, the target PKPD attainment will not be good if we use separate Avibactam. It will be the same thing like using ceftazidime Avibactam and Astronam.
Fine. So I think a combined product which has been tested in the lab and has been manufactured based on PKPD data would obviously score over jugaad like giving Avibactam with some cephalosporin. And obviously without data, nobody would encourage using that. Plus, in these sick patients, you would go with the tried and tested combination rather than experiment, unless and until cost is a huge challenge where you would have to do the best you can. But in those kinds of situations, it is better to go with the polymyxin-based regimens where you would have a better coverage and at least some assurance based on the data and evidence we have for polymyxin-based combinations. That is what I would do. Anything else? Okay. So Sumit had a question, and we'll wrap it up after that.
What is the kind of percentage of KPC that you see in the Klebsiella? Because the reason is that, you know, if the KPC is not there, the role of Avibactam in a Klebsiella, you know, you could have another BLI with Astronam. I'm just theoretically, I don't use it, but I'm just saying. So one is that, the cost for that. Second is, it's a comment, is that the PBP3 rates in my hospital now, our antibiogram just came 43% in E. coli now.
43% for?
E. coli PBP3.
PBP3.
So it's a very high.
Very
so,
high.
Yeah, so
okay.
Its role in ceftazidime Avibactam Astronam in E. coli, as sir was pointing out, is very iffy if you are going for an empiric one. So
I think most of us are deviating from the synergy combination in E. coli at least,
yeah.
and we are going back to the older polymyxin, at least empirically. Yes. Then you can de-escalate if it is susceptible. There was a new product, plasomycin, introduced for that same kind of stuff, but again, it doesn't work for PBP3. So again, the same problem is there.
It's expensive and doesn't help.
Dr. Hegde, your...
Yeah, actually, we were thinking that Pfizer is going to cannibalize ceftazidime Avibactam, but if there is no NDM, it's a pure oxide, it's probably better to go back to ceftazidime Avibactam alone, but that is safer. Astronam Avibactam has some hepatotoxicity, so if there is no NDM, there's no point in using Astronam Avibactam, go back to plain. Of course, you don't need Astronam at all. We don't need Astronam, I'm saying ceftazidime Avibactam.
So if it is Oxa or KPC, you can just go with ceftazidime Avibactam.
KPC rates that I see across the country, I mean, in my ICU, it's about 5%.
Okay.
So across the country, it's anywhere between 1 and 6%, if I'm not wrong.
But it won't matter, Avibactam will cover KPC.
No, that's what I'm saying. If the KPC So you don't need to block the KPC as much, right?
No.
So,
No, but avibactam.
so but the
you need
focus should
oxa,
be
no?
NDM.
Oxa,
So
oxa,
Astronam is
oxa,
going
you
to
need
the main
block
one.
oxa. Mainly
So-
the oxa.
Exactly. So main one is going to be the Astronam, and you can use another BLI which
But they
covers
won't
for
work against
Oxa.
oxa.
Oxa 48.
Oxa, they won't work against.
But sometimes co-production
Hello.
will happen with KPC as well. So isolated KPC I have not seen, and most of my ICU is Oxa NDM. So again,
I
Thank
think in interest of time, sorry, Dr.
Yes.
Dumra.
Okay,
I have
thanks
to
a lot.
respect
Thank you.
it.
No, you can
Thank
continue.
you.
I would request.
I don't mind not taking my lecture.
No, no,
This
you-
is more important.